really like it because it lets you kind of lock your information. Once that test is over, you're never tested over it again until you're like yeah, so I'll study, like if I take a moment, I need a nap, and I'll take a nap and then I'll get up and study. Me, I'm a night owl, so sometimes I'll be up till like, midnight or 9, whereas other people, they like to go home and they'll study. I would say a couple hours a night. Sometimes less, depending on how well you're grasping the content, and maybe something you already learned in school you remember really well, so you don't mind studying as much. This stuff, I feel like I have to study a lot because I never took the it just kind of depends on your study style and habits, but I pretty much study all weekend. And some people may be different, but I think study all day Saturday, all day Sunday, on Sunday. So it's a lot. The other thing is it's 1 year. So it's 1 year of this, and then you start into your rotations is either a month or 2 in each location. Some of the ones that are required, like emergency medicine, primary care, those are 2 months long. And there's some you get to pay, like my sister's a dermatologist, so I want to do a dermatology rotation. But that's not one that everyone has to do. They're not interested. That's a really good one. And then, so you kind of get to pick. Yeah, it depends. So if you're working in a dermatology clinic, it may be like 8 to 5, Monday through Friday. If you're in the ER, you may be working, 3 12-hour shifts during the week. Because he starts to do it, and I'm like, so we will never see each other. We all come back here once a month to take a test. Yep. Right. So you'll have what they call a preceptor, who is either a PA or a physician that kind of oversees you, and you work with them with anything like completely like you would walk out and like, this is what I would say is what's going on with the patient, and they'll look over your note and your information. 1 year. Yep. But they will, and that's why it's so intense, because they are preparing you to be able to go out and start taking care of you for a year. It's super intense. Like a lot of people who read that, in 2 years, so they tend to have a lot of free time on the weekends and stuff like that. But there's for 4 years, you're a year and a half. They go with no residency.
That's like a senior. I did this all pretty much. I've got to boxes on Friday. I did not.
And just change jobs. I don't have to do anything.
You got a handout. I did not get that. Okay, what do you know about platelets? They clot. Okay, they don't clot, so they aggregate. Okay. What else do you know? What? They attach to von Willebrand factor into each other. Okay. What else? Short lifespan. What else?
On the parasite, little pieces of that.
Okay. Didn't know that. I'm sure. I'll buy it. Okay, what else? Okay, let's talk a little bit about their biology and their life. So platelets, for the most part, are in 2 forms. This is their circulating form, this one right here. Round, discoid shape. Those others are activated platelets. So what we would like to do is keep them out of that activated state. So platelets are in your bloodstream all the time. Their major job is that if you have a cut in a vascular wall disruption, is that they are right there along with the coagulation factors to repair a vascular breach. It may be that they do it all the time with microtears and you're not even aware, or you have a major cut and you get to see that, the bleeding stop, and that's because those platelets act very quickly. So let's go up to the top. The reason why we're talking about this is that antiplatelet or platelet effect is the major, based on those pictures we just looked at, that is our major worry in an acute coronary syndrome, because it's that thrombus that forms that occludes off the vessel. If it occludes it enough and quickly enough and there aren't good collaterals, then you get sudden death, or you have a larger infarction, or you have ongoing symptoms. So that's why we're very concerned and want to modify the platelets behavior. So the recommendation is that all patients get antiplatelet therapy that are, we're still talking about non-STEMI and unstable angina. Antiplatelet therapy includes aspirins, the P2Y12 receptor block inhibitors, and the glycoprotein 2B3A. We don't use the 2B3A hardly in non-STEMI, they are used more in the STEMI. So when we're using aspirin and those P2Y12 receptor blockers together, that's called dual antiplatelet therapy. So DAPT, I gave you, there's a whole guideline written on it, so that tells you how important it is. Why would we do that? Why would we do two different antiplatelets? They have different mechanisms. They go after different things that the platelet does, just like we use two antibiotics together, two different types of blood pressure medicine to lower. It's because they have different mechanisms. Because there's lots of different things that the platelet can do to recruit and then to aggregate and activate and aggregate. So dual action or dual therapy reduces the risk of cardiovascular death, non-fatal MI, and stroke. So all those big cardiovascular outcomes are reduced by using dual platelet therapy. The recommendation is that you treat them for at least 12 months after an event. Some studies look at it up to as much as 36 months, but you need to look at what the patient. Because these drugs put them at high risk for a bleed. And if patients are already at high risk, then a bleeding diathesis, a major bleed, can be lethal. So it's always a balance between what we're trying to get to happen and what could happen. The receptor, the P2Y12 receptor inhibitors are listed there. There are others. These are the most common ones used. So let's go back now that we've kind of established why we're going to do it. Let's look at the platelets and their action. So platelets move along in the bloodstream until there is a breach. When there is a breach in that vascular or an interruption in that vascular wall, tissue factor is released, and that's what starts off the whole thing. Because tissue factor then, what part of the coagulation cascade does it then affect? It's a cofactor for what? The conversion of 10 to 10A. Okay, so right to the common pathway. So activation of, so platelets are activated then, and once they are, this is the activated form. Okay, let me see. Looking at platelets, just this is kind of morphology. This is the discoid shape. They are so rich in just junk. They carry so much stuff around. They have dense granules, alpha granules. They can secrete all kinds of things. They can recruit other platelets. They can help the other platelets activate. They can cause and initiate tissue repair at the breach. So they can affect local change, and they can plug up a vascular tear. So they have lots of things that they can do. This is an activated platelet. When they activate, that 2B3A receptor becomes active. That's important because it can bind fibrinogen. And it's that fibrinogen 2B3A complex that then causes all those cross bridges with all those other platelets. There are 40 to 80,000 receptor sites on every platelet. So you can see how sticky, why they're so adherent. They've got to be able to adhere to the vascular wall, and they've got to be able to adhere to each other. Think about it, in a blood vessel, there are shear forces that are constantly going over those platelets that are trying to stop up a bleed. Okay? So you got blood that's still being pumped over it, and you got those platelets that are having to try to do all this to keep you from bleeding to death. So that stickiness is really important, your ability to adhere. Collagen that is exposed in that when that vascular wall is torn is one of the main activators. That's one of the things that all those little fibrils will attach to, is to not only to each other but to the collagen that's been exposed. So we've got activation by collagen, thrombin, and ADP, which actually the platelets release. Shape change occurs, we get those elongated pseudopods. We've got adhesion to the vascular endothelium. We talked about aggregation occurring. On the next page, you get secretion, so you have lots of things secreted. From those alpha granules, you have fibrinogen. So not only is there fibrinogen in the blood, the platelets can secrete their own. There's the von Willebrand factor. Again, it's part of that endothelium, but the platelet can also secrete it. Platelet-derived growth factor, platelet factor 4, P-selectin. These are things you'll see commonly in the literature that are talked about in terms of activating factors, or they are targets for potential drugs. Dense granules contain the ADP, histamine, serotonin, other substances. So what do they do with that? They recruit more platelets. They aggregate. They stabilize a platelet aggregate. They can locally vasodilate, or they can vasoconstrict, and they can start the process of tissue repair. So very important. The other is they have a procoagulant that they can release, and it's like a thrombin accelerator. So they can increase the formation of that clot by themselves through that procoagulant. Okay, things you've heard before? Some, okay. So what we're going to do then, let's look at some of these things. So there's there's your factor 7 and your tissue factor. There's your membrane, and there's the activation of 10 to 10A. So that tissue factor, remember, is an inducible system, that extrinsic factor. And then you've got a common, you've got then the access to the common pathway right here, and then the conversion of prothrombin to thrombin and fibrinogen to fibrin. We're going to do a lot of drugs. Most of our drugs are going to target fibrin, thrombin in some way, or fibrin. On the bottom of my page 13, what's page 12? 12. So in the bottom of page 12, these are the classifications for the COX-1, the P2Y12, and the 2B3A inhibitors. So these P2Y12 are the major antiplatelets that are recommended in a non-STEMI. That receptor binds ADP. So you'll also see them referred to as ADP blockers. So ADP is important because it causes activation. So it can cause that conformational change in the platelet. And it's also involved in recruiting. So that is how that drug works. These drugs work. Next page, let's look at the different type. There's about 4 of them. They are very different. They all do the same thing, but they have some uniqueness that gives them their place. That ticlopidine that I didn't put in there is Ticlid. It was the oldest product in that group, and like most first drugs, there's so many problems that they create other drugs to address those. So Ticlid, still around, just not used very often anymore. So clopidogrel, which is Plavix, Brassagruel, which is Effient, Ticagrelor, which is Brilinta, and then the newest one, Cangrelor, is Cangrel. So let's talk about each of them. To just give you a perspective, Ticagrelor is a third generation. It gets around most of the problems that we have with Plavix or clopidogrel and Brassagruel. And so it's preferred. You'll see in the guidelines, it's usually the first antiplatelet, unless you have high bleed risk, and then you go with clopidogrel. The last one, that Cangrelor, it is the IV one. It's only IV. So when you need immediate effect, that's the one to use. So let's look at their differences. Just want to draw your attention, there are several slides here I pulled that just look at different, give you a different way to look at our visual example of the process of platelet activation and thrombus formation. And these are great videos. I highly recommend them. Okay. So Plavix. Plavix is a first line, can be used. The big thing to note with it requires biotransformation. It is a prodrug. It is inactive. It's also not very reliable. You just can't always count on it to show up when you want it to. That's why that Ticagrelor has become a one that people prefer. So if you look at clopidogrel and Brassagruel, they both require transformation. Clopidogrel requires 2 steps. Okay. So it goes to the liver, and it has 2 different enzyme systems that transform it into an active drug. Brassagruel requires 1 step. Ticagrelor, just look up here. Just look up here. I'm going to hit it again. I'm just showing you the difference. Clopidogrel, Plavix, 2 steps. They all work on the same receptor. Brassagruel, 1 step. Ticagrelor and Cangrelor, no transformation. Okay. So those are the big differences. That's why this one is preferred. And that's why probably clopidogrel has so much variation in its effect, is because of those steps. How fast, so enzyme systems differ in their speed. Genetically, you differ from each other in the speed of those enzymes. And so that's why sometimes they don't work as fast or to the same extent that we expect. Significant drug interactions with clopidogrel. Proton pump inhibitors are one of them. It's recommended you avoid using them together. One of the guidelines I gave you is just on that. Okay, so it tells you it's important. If they'll write a guideline on the PPIs and this class of drugs, it's a problem. So it decreases the effectiveness of clopidogrel when you use them together. Statins can do the same thing, different mechanisms. Under the next step is the doses. The thing to take away with these antiplatelets is you have to use a loading dose. Using a large loading dose will get you what you want faster. You'll get platelet inactivation more quickly. So they're looking at timed inactivation, and the different studies measure that. The other way they differ is how fast they work and how long it takes them for their effect to go away. Another reason why Ticagrelor is preferred is that it's fast on, fast off. Clopidogrel, 5 to 7 days to get max, 5 to 7 days to get rid of it. So if you're expecting that somebody's going to need an intervention, an invasive intervention, then you might want to use a shorter acting drug. Okay? That would be also why the IV. If you think this person's going to have to get a cabbage, and maybe that isn't part of your protocol, then you would use a shorter acting drug with faster on and off. The other thing they differ in is bleed. Yes.
What's a cabbage? People keep saying this word, but we never actually talk about it.
Coronary artery bypass graft. Okay, it's one of your abbreviations. So people just go down to cabbage. They'll also say 2 vessel, 3 vessel. That tells you how many were bypassed. So that'd be another 4 vessel. 2 to 4 vessels would be in the common range. The other is when to administer. Clopidogrel and ticagrelor you can give before an angiography. Prasugrel, they recommend you don't give it before angiography because of the risk of bleeding. They also differ in their bleeding rates. Clopidogrel has the lowest. Ticagrelor has the highest. These are things I expect you to know. I know you're wearing out because it's the end of the day, but this is just too good. Okay? This is why they're different. Clopidogrel resistance can occur. So resistance is defined as when no clinically meaningful change in platelet function after treatment happened compared to baseline. So it's another reason why people move away from it, because of the unreliability. So that's what they mean by clopidogrel resistance, no platelet effect. It sometimes is the drug of choice. It depends on the procedure that's going to be done and the person's bleeding risk. If they are high risk for a bleed, then clopidogrel is the way to go. It's lower risk of bleed than aspirin. So that tells you a lot. Prasugrel, it is pretty similar to clopidogrel. I would consider them about the same. There are some differences. Again, there's the loading dose. Circle it. I've said it 3 times now, so it's important. It's that concept. So you have to load these agents. Do not use them before angiography. This one. It's also a prodrug, has to be metabolized. It's 5 to 9 times more potent than clopidogrel. So it was one of the second ones to come out, so that made it a benefit. Fewer drug interactions than with clopidogrel, so an advantage. The problem with it is it's bleed, and it's also causes problems with platelets. So it can cause TTP, which is thrombotic thrombocytopenic purpura. For that reason, I think that's why it's fallen more out of disfavor. You can still use it, but you have to be aware it carries some different risks than the others do. So the jewel in this group is ticagrelor. That's Brilinta. What a name. If you were a drug, would you want to be called Brilinta? Okay, requires a loading dose. Note the difference. Aspirin, you still give aspirin before. Usually you're given all this stuff as they're coming in the door. So you're giving them aspirin, you give them antiplatelet same time. But if they use subsequent aspirin, which most of these people will be on aspirin afterwards, a baby aspirin every day, is you have to give a lower dose because it interacts with the ticagrelor. So here you're going to give less than 100. So your baby aspirin of 81 milligrams will work. Mechanism of action is different from the other two. It is a non-competitive reversible. So it gets on the receptor and off of it faster. That's another big advantage here. Especially if people have to go into procedures or they're going to bleed. The drug gets on and off more quickly. Next page, onset more rapid and consistent than clopidogrel, quicker offset than prasugrel. Does not have to be activated. So it does not, it's not a prodrug. It does have 3A4s, cytochrome P450, 3A4 isoenzyme. It does have effects on those. It affects them and it can be affected by them, by drugs that interact with that system. Contraindications are a little bit different. It's the same as if you've got active bleeds, but it's also if they're having AV block, especially second to third degree AV block. Those are contraindications, or symptomatic bradycardia. Adverse effects, bleeding is number one for all of these. It has a weird one though. It has dyspnea with it. None of the other ones have that side effect. Can occur early on in treatment. It can come on, go away, and not show up again, or it can persist. But it's not linked to a cardiac effect. It's more pulmonary effect. Yes.
Do you know why you're not supposed to give it a second and third degree AV block?
I don't know. Off the top, I don't know. Pangolin is the IV. It binds selectively and reversibly. It gets on and off. Its onset of action is 2 minutes. Okay, that's compared to clopidogrel, which is hours. And platelet refunction returns to normal within 1 hour after discontinuation. So around like a percutaneous intervention, that might be one you want to use. Questions about those? Okay, look at the place in therapy then. All patients with non-STEMI should get a P2Y12 receptor blocker, along with aspirin. If patients are going to have an invasive procedure, then give ticagrelor. It's the most potent. You look at the Plato study. It had better. It was superior to clopidogrel in its effects. If you're using more medical management, it still is considered the drug of choice, ticagrelor, superior to clopidogrel. Clopidogrel, though, should be used in those who are higher risk of bleed, and that goes to the Trilogy study. Questions about those? Let's go on to the anticoagulants then. Mine's page 20. What page is it? 17. So at the same time you're doing all this, you're also going to put on an anticoagulant. So you've knocked out the platelets. So when you're looking at the ability of the body to clot, you've got platelets and you've got the coagulation system. So you're going to have to affect both of them. So the anticoagulants are going to work on that side. And here it's all injectable. We're going to use heparin and heparin-like agents to do that. And we're going to target thrombin primarily, or factors that affect thrombin. So under key points, anticoagulants are given IV or subQ. The ones that are included are the unfractionated heparin. That's the oldest one. It's been around forever. The low molecular weight heparin, which is a modification of unfractionated heparin. The direct thrombin inhibitors, which would be fondaparinux and bivalirudin. Again, anticoagulants are started at the same time. So when you're doing your aspirin, your antiplatelets, your anticoagulants, all of these at the same time. Look under heparin, move down to it. So heparin, so we have unfractionated heparin and a low molecular weight heparin. The low molecular weight heparin came out in response to the problems that we had with heparin. But they still have very similar effects. They're indirect thrombin inhibitors. What they affect is antithrombin. So in part of that coagulation cascade, you have cofactors or factors that associate with the clotting cascade that are natural anticoagulants. So thrombin is one of them, protein C, protein S would be others. So they terminate the effects of the coagulation cascade so that it doesn't run amok. So antithrombin binds thrombin in this case, and it will, it inhibits, antithrombin hits thrombin, and it neutralizes thrombin activity. And it binds, but it binds it at a very slow rate. When heparin binds antithrombin, it speeds up the process 1,000-fold. I tried to put a little emoji there that was going, wow, and it blew up my handout. It stopped everything, and I lost about an hour's worth of work. So, that's what I get for being cute. Okay, so I just put in wow. All right. So here's the different, it was like matter and antimatter. So you got unfractionated heparin, very long. Low molecular weight heparin is just a fraction of that, and then you have fondaparinux, which is just this portion of the, and it shows you all the way through each of these. So when thrombin binds antithrombin, you can, heparin is going to bind to that antithrombin. So the difference with the low molecular, So the unfractionated heparin will hit more parts of the cascade. So you hit the intrinsic side, 9, 10, and thrombin. Low molecular weight heparin pretty much just affects the common pathway, just 10. So it doesn't have as much. It does have some effect on thrombin, but it's smaller, much smaller. So that's the difference in those two. So let's look at underneath with unfractionated heparin. Some things to remember. It's weight-based. Okay, stay with me. So it's weight, so it's units per kilo. You always give a loading dose. Okay, so note that, it's different. So you always give usually 5 to 10,000 is your loading dose. Then you'll start it on units per kilo. And then what are you going to use to evaluate the coagulation time? APTT, not PT. An activated partial thromboplastin time. So that's comparing how long does it take the blood to clot compared to a normal standard. So it's measured in seconds. So you're going to keep titrating the dose up until you get that APTT in the range that you want. Here's one thing to note, circle it, put a note out that says Letassy says this is important. You can use it in people who have renal insufficiency. You cannot use low molecular weight heparin or the other anticoagulants in people who have renal insufficiency. So here's your go-to drug. The problem with heparin is that it affects platelets, and it can cause a syndrome and take your platelets out. We'll talk about it more when we go through the antiplatelets, but that's one of the problems with it. If you move over to low molecular weight heparin, no loading dose. It's on units. It's actually milligrams per kilogram, and you give it sub-Q. So heparin is IV, low molecular weight sub-Q. You can give heparin in renal insufficiency. You cannot do that with the low molecular weight. The one up there, enoxaparin, is the most common. Lovenox is the trade name. It is not as hard on the platelets, so it's a little bit safer in that regard, and may be preferred. You also can turn off heparin quickly. You can't turn off low molecular weight heparin as quickly. So the type of procedure or what you're planning to do to that person may dictate which one you want to use. Fondaparinux or Rixtra, it is a 10A inhibitor. It would not be first line. Your heparins would be first line. This would not be a first line drug. So selective for 10A, so it has no effect on thrombin. You cannot use it in renal insufficiency. And it's also subcu. It's only once a day, whereas Lovenox is usually twice a day. So an alternative, especially if people are at increased risk of bleeding. The last one is bivalirudin. It is a direct thrombin inhibitor, so its mechanism of action is different from the heparins. If you have a heparin-induced thrombocytopenia, which is called HIT, then you can use this drug instead. And you'll see if you'll look through that, take the time to look through that table, they have times where they prefer this drug over the heparins. Big thing I want you to know is that its mechanism of action and what its indication is. They all cause bleeding. Okay, next page I've given you a flow diagram for the Stemi. Pretty much we're going to be using the same drugs, but we'll use them in different, maybe in a different time frame. The one thing I do want to cover before we stop though is, and then we'll be done, are the fibrinolytics. So what page are your fibrinolytics? 20? So STEMIs, these people are the most at risk for dying, because they've got a thrombus that is causing ST second elevation. They're having so their MI we're worried about. We're only going to use fibrinolytics if PCI is not available, or you can't get to it. You're near a facility that doesn't do that. So a percutaneous intervention is preferred because it's better at opening a vessel. Somewhere in there I put down, it's 90%. It can open a vessel to 90%. That's huge. Fibrinolytics are about 60%, so they're not quite as good. They carry other side effects with them. So what these drugs do is they are going to interact, they are plasminogen activators. Look on the next page. And they're specific for fibrin. So what they do is they activate plasmin, which will then cause that breakdown of the fibrin, and you get those FDPs, or fibrin degradation products. So these drugs work very quickly, very fast. The clot busters, they're often referred to as. There are 3 that I have given you. They all differ with some degree of ease of use, or how quickly. They all are quick. Adaplase is 2nd generation. The oldest one was streptokinase. It's all over on the market. So Adaplase, plasminogen activator, fibrin specific, very short half-life, 3 to 4 minutes. So it gets in there, does its job, it's gone. But it's more complicated to use and dose than the other 2. The next one is Retaplase. It's easier to administer, very similar to Adaplase. The last one, Tenecteplase, is a 3rd generation. It is usually the preferred one because it's one time, one injection, it's weight-based, it's easy to figure the dose, it's easy to administer. And it's very specific for fibrin. Highly resistant to any ability to inactivate it. Lower bleed rate. So they need to be administered quickly. It's recommended within 30 minutes, best if within 2 hours. There is some thought that it could be even given later, but that's your best for the patient. We do not give them to unstable angina or non-STEMIs, okay? Because they're just not as effective. The clots are not fibrin rich, and so they just don't have an effect, or as much of an effect. Look on the next page, contraindications. So here, if they've got a bleed, if they have cancer, because a lot of times patients with cancer have lots of problems or abnormal clotting cascade effects. Aortic dissection, bleeding diathesis, if they've had the drug within the last 2 months, that puts them at higher risk for a bleed. If they've got an intracranial bleed, which is what that ICH is, those would be contraindications to using a fibrinolytic agent. The last are those 2B, 3A blockers. They are a more third line. They are only used in STEMIs, and they're used for platelet aggregation. I put one of them down here, that F6-amab. What do you notice about its name? What does that tell you? It's a monoclonal antibody. Anybody remember what the XI in front of it means?
How much?
Yeah, it's chimeric, so it's about 65%. So it still has some mouse effect. So these are IV. Bleeding, again, is the big one. Just want you to know what they are, what they do, when they're indicated. That's a lot. It's a big one. I'm never going to do this one from 3 to 5 again. It's too much. It's like too much for your brain. Okay, questions? Probably. Okay, I will see you tomorrow then with anti-arrhythmics. Another one. Thank you.
Oh, I know. I got
The nice thing
Yeah, maybe that's what it is.
I would say put them in, and a lot of times like, you can team up with other students and like you'll do this one and call the other one, they go sweet, and else do that one, and then go to that. Our class is really good about working together and very
Is he just
I like how you like the smaller classes,
Bye, guys.
the nice thing, so one thing about our system is that like we are not going to have a
Better?
so everything we cover this week will be on our system. So it's going to have some pharmacology, it's going to have some physiology, whereas like OU's program, there are more than classes. They may have 3 weeks of pharmacology, but then they have a test in their pathophysiology classes over GI, but their pharmacology is over cardiology, and so they can be all over the place.